So as people are trickling in and joining us here, I'm going to give us a few minutes to get some more people into the Zoom, and then we'll get started. Welcome to those of you joining us right on time. I'm so impressed. We'll give it till about 11:33 Central Time, and then we'll get started right at that time. I usually try to do like 5 minutes, but I have a feeling that we're going to have such a long and insightful discussion that I don't want to take up too much time from our fantastic speakers today. Thank you, everybody. As you trickle in, we're going to get started in about 1 minute. All right, welcome everybody. We're going to give it in about 30 more seconds, then we'll jump right in and get started. Okay, everybody, welcome to the first ever book event through the Women in Medicine Summit and Impact. I am so excited for everybody to join us today. I know we're going to see people trickling in. It's the middle of the workday, so I know it's a little bit of a challenge to find the time. So thank you for those of you who are able to join us today. This session is going to be recorded, so for those of you who want to share it with friends or colleagues afterwards, because I'm sure it's going to be a great discussion, you can absolutely share the link. We'll have it available for people after the session is done. So just to kind of give a little bit of background on how this all started, my name is Dr. Shika Jain, and I'm the founder and chair of the Women in Medicine Summit. Through the Women in Medicine Summit and Women in Medicine organization, I've met some phenomenal women, both in healthcare and who write about healthcare. And phenomenal physician, Dr. Jessie Gold, reached out to me and said, "Have you heard of Emma Goldberg?" And I said, "I've heard the name. Why should I know about her right now?" She said, "Well, Emma has written this phenomenal book, and I want you to find a way to share it with the women in medicine community, because it is such a powerful story and such a powerful book that it needs to be shared." And so I said, absolutely, I would love to do that. And that is how this Life on the Line book event happened. I'm going to start by introducing our two phenomenal speakers today, and then we're going to jump right into the conversation. So today's event is based around the book, Life on the Line, Young Doctors Come of Age in a Pandemic. And it was written by Emma Goldberg. Emma is a reporter at the New York Times, and she writes for sections such as Health and Science, Styles, Gender, National and Culture, and many others. Her cover stories have featured campus tensions, surgeon moms, young women running for office, and low-income medical students. Since the start of the coronavirus outbreak, she has turned her focus to the lives of students, physicians, and nurses battling the pandemic. She is the winner of the News Women's Club of New York's Best Journalist Award and the Sidney Hillman Foundation Sidney Award. She received her BA at Yale and her master's in philosophy at Cambridge University. Our other fantastic speaker today is Dr. Rana Awdish. Rana is the author of In Shock, a critically acclaimed best-selling memoir based on her own critical illness. She is a sought-after public speaker, delivering inspirational keynote addresses to groups ranging from professional medical societies to members of Congress to organizations combating homelessness. She's a pulmonary and critical care physician. She serves as the current director of the Pulmonary Hypertension Program at Henry Ford Hospital, and also serves as medical director of care experience for the system, where she has integrated compassionate communication strategies and narrative medicine practices into the curriculum. Her narrative nonfiction essays have been published in the Examine Life Journal, Intima, Chest, and the New England Journal of Medicine. She's written editorials for the Harvard Business Review, Annals of Internal Medicine, the Washington Post, and the Detroit Free Press. Her essay, The Shape of the Shore, was awarded a Sidney by the New York Times and was nominated for a Pushcart Prize. So I don't have to tell anyone who is on social media. Both Dr. Rana Awdish and Emma Goldberg are phenomenal advocates. They are fantastic writers. They are wonderful storytellers. And I am absolutely honored that they agreed to join us today for this conversation. And so without any further ado, I want to open the floor and pass the baton and pass the microphone over to Emma and Dr. Rana Awdish for this very important conversation.
Thank you so much.
Thank you. I'm so thrilled to be here with Dr. Awdish, who I have admired for so long and whose writing has really impacted my own. And I'm just thrilled also to be here with this community of doctors, and especially women doctors, who are pushing the conversation in so many important ways, especially at this moment. So thank you for bringing us together, Shika, and thank you to all of you for being part of this.
Yes, and Emma, I just have to thank you personally. It means so much that you would turn your journalistic skills to this issue of new doctors being asked to work in the pandemic. It feels so urgent and important what we're asking of physicians, especially young physicians right now. And I wonder if you could tell us what was the first germ of this idea? What was the inspiration that led you to writing this book?
Yeah, well, I'm so glad you asked this, because I really, it wasn't the kind of thing that felt like the most natural to me, because I had for a long time sort of thought as a non-physician that it might be stepping on toes, or, you know, that there might be a sort of boundary where it wouldn't be appropriate for me to kind of step in and do that narrative work. But one of the things that really turned my eye toward this issue was I have a friend who is in medical school now, and he called me a couple of years ago, and he said he was at Harvard Medical School, and he had started filling this notebook with all of the issues he was seeing day to day in his training, on rotations, and just over in, you know, meals and conversations with classmates that he felt needed to be exposed in some way. And this is an amazing person named Adam Beckman, who actually is currently working with the White House on its COVID response. So he had filled this notebook with all of these issues that he thought, you know, ought to be covered narratively and journalistically. And one of the points he raised was that medical students aren't always in the position to call attention to their own issues and needs and experiences, because they're in this very tenuous place of knowing that they're in this rigid hierarchy. You know, they're constantly being evaluated. They're constantly looking toward what the next step will be, particularly toward residency placements and licensing exams. So it's challenging to feel empowered to kind of speak out and call out inequities and other problems in the field. And so he sort of got the wheels turning in my head to think about, what is the role for journalists in telling the stories of particularly medical trainees who might not always be in the position or have the platform to share their own experiences? And that was one of the first kind of conversations that drew me toward that realm of reporting. And the article that came out of that was called I Have a PhD in Not Having Money. And it was, and it's about students at Harvard who come from low-income families and kind of come to this culture of money and just kind of constant cost and debt in medicine, and what that encounter looked like. And so from there, I started hearing from lots of medical students and residents and others who were always filled with ideas for stories that they wanted to see reported in the Times. And that led to the early weeks of the pandemic, when I heard about those in New York City, particularly, who were graduating early and heading right to the front lines. And that was something that captivated me right away, because it was this moment of sort of paralysis for so many of us. And particularly for journalists, we're used to being out in the thick of things. And instead, so many of us were stuck at home, isolating in our apartments, you know, to follow public health mandates and trying to report as much as we could from afar. And so I was really captivated by the idea of these young people who were just moving right to the front lines. And in a moment when we knew so little about transmission, about protection, about risk, they were just delving into the crisis and doing what they could to help. And that was a story that kind of stole my heart, and that I knew I wanted to continue following for a longer period of time.
And it's clear from what you've written that you were very intentional in who you chose to follow. As you mentioned, medicine, as a structure tends to be fairly moneyed, and there are people who enter it generationally. And then there are people who are working their way in from very different backgrounds. Could you tell us about the choice there to follow first generation Americans and people from Hispanic backgrounds?
Yeah, I'm so glad you asked that, because that was certainly something that was a real priority for me, because I knew the kind of statistics about, I think it's under 6% of American physicians are Hispanic and just around 5% are African American. It's these really, really small numbers that actually have not grown that much over the last few decades, even though there's been a slight uptick in representation of communities of color within medical schools, but it's been slow and just a more challenging battle than I think a lot of people might have anticipated. And so I wanted to highlight the stories of people who don't always see themselves represented in narrative medicine and really in the field overall. And one of the moments that kind of has stuck in my head with that is I was speaking with a young woman named Gabriella, who's now a resident at NYU. And she was talking about how when she was growing up, her mother would drive her nearly an hour out of the way of their hometown to see a pediatrician who was Hispanic. And Gabriella never understood growing up, what was the big deal with that? Why would they go on this long commute just to go to a pediatrician who is Hispanic when they had other doctors who were much closer to them? And she kind of understood it more and more as she grew up, and as she realized that she too aspired to be a pediatrician. She realized how huge it had been for her to have that example in her head growing up, that someone like her could enter the field. And at the same time, there have been these moments she talked about when she faced skepticism about whether she could be a doctor. People suggested maybe she should pursue some other kind of healthcare work, whether it was being a nurse or just something else entirely. So that she really did see firsthand how powerful it was to see herself represented. And so I kind of wanted to do the same with these stories and have people who pick up this book see just the really broad representation that there is within the field, whether it's someone who is a first generation American whose parents were somewhat frightened by the US healthcare system, someone queer, or even, an Orthodox Jewish woman who didn't really work on the Sabbath, just people who are seeing their identities bump up against the work in all kinds of thorny ways. And that was important to me to capture.
And I wonder, did you feel in choosing these people to represent, I felt there was a tension between their sense of wanting belonging and medicine asking them to almost prove their worth, prove that they belonged. And as a journalist, I wonder what your perspective on that culture is, because from the inside, I think it's very toxic.
Yeah, that was something that was really new to me as someone who had really only looked at the field, from the outside. And so it was fascinating getting to sort of be immersed in the experiences of these young doctors who I followed and see it through their eyes. Because I think there really can be a sense of almost hazing in some ways, where you're constantly having to jump through hoops and prove yourself and question yourself. And there's all of these power dynamics. And I think we know that can sometimes be to the detriment of patients, because you do want a culture where people feel comfortable asking questions and speaking up when they're uncertain, or when they see, their superiors doing things that they think might be problematic. I think everyone really benefits from a culture of openness and honest communication. And that was something where I actually saw some degree of, you might even call it progress during the early weeks of COVID, because I think there was a recognition that everyone was so new to the work of treating COVID patients and to understanding COVID, that there was almost a leveling out of experience and knowledge amongst people of all different levels within the field. So you had moments where, attending physicians were turning to these residents or interns even and saying, I don't know about this particular issue. What do you think? And there were whole new levels of honest and open communication. And I think that was in some ways facilitated by the all hands on deck atmosphere in the hospitals at that time. The fact that there were really senior doctors, there were surgeons, I heard about changing bedpans. There were deans of medical schools volunteering, in whatever wards or ICU or wherever they were most needed. So there was a real, all hands on deck atmosphere that I think in some ways fostered more open channels of communication. Although I'd be curious to hear too, whether that resonated with your experience.
No, absolutely. I can remember one of our surgeons who is an African-American man who got COVID very early and recovered. And our environmental services staff were so concerned about contracting the disease that he served as an EVS worker and would clean the rooms of the COVID patients so they wouldn't have to. And it was this real act of solidarity and I think an acknowledgement of our humanness and our interrelatedness that we don't often have in medicine. And another way I saw that manifest in your book was how early on there really seemed to be a sense from the patients, an awareness of the risk that the physicians and nurses and staff were taking on in caring for them. And that's dissipated, to say the least. I think we've entered a different stage of the pandemic. And I wonder how you frame that for yourself. How are you understanding that change?
That is a really powerful question. And it does speak to, I think it's a challenging moment to be having this conversation because the context just keeps changing and the facts on the ground. And I think I am hearing from healthcare workers that I'm speaking with right now, a sense of this kind of new tension that exists in hospitals right now, in patient-doctor communication, in doctor communication to the others in their lives, whether it's family members who won't get vaccinated, whoever else they're speaking with about this, because we're reaching a phase where we kind of know what the script is in terms of what works to fight this virus. And yet there is so much resistance to some of that in so many parts of the country, and a lot of inequity in how the response can be distributed around the world. But, you are seeing spread that, researchers are saying the spread right now is being fueled by the unvaccinated. So we know that, and certainly there are breakthrough infections, although it seems right now that predominantly that's because of the spillover into vaccinated populations from transmission among the unvaccinated. And so it's a moment when we know what works to fight it, and we know exactly what needs to be done, whether it's masking or vaccinations, and yet we're still seeing cases continue to rise, hospitalizations continue to rise, and in parts of the country, deaths rising. And so I do think there's a new level of burnout, frustration, and angst on the part of healthcare workers and their families that I am hearing as I speak with people. And people kind of feeling like we have been in this crisis for a very long time now, and that burden has been unduly placed on healthcare workers. And at this point, they know what works and they don't want to have to keep doing, this soul-wrenching work. And I certainly don't need to tell that to you, and probably a lot of others on this call, you know that firsthand. But I'm definitely hearing a new kind of tension, and it is interesting to compare to the early weeks of the crisis in New York. Because I remember viscerally last spring being in New York when everyone was locked down in their apartments and the sound of sirens was ubiquitous, and people were sanitizing their groceries and, not really sure. They were wearing gloves whenever they went outside. No one knew exactly how to navigate the risk and the uncertainty. But there was also a sense of collectivity and people having each other's backs. Another journalist I was talking to recently was reminding me how people would walk around the streets of New York and kind of make eye contact with each other and give each other these little nods of solidarity and comfort. And I think there's been a shift in the mood because the crisis has continued to take turns that doctors and epidemiologists anticipated, but maybe the public weren't fully prepared for.
So I have a question to jump in here for a second about burnout. And, you talked very, very much about how healthcare workers and physicians and nurses and everyone has been burned out. And I think that was the case pre-pandemic. And then you just created a kind of bigger situation where even more burnout is happening, and kind of this pandemic where it seems like it's never going to end at this point. But when you were reporting on all of this, I've talked to a lot of journalists who also were facing a lot of burnout, just reporting on these things and writing a book like this, where a lot of people don't hear the stories that you are using this book to tell. Most lay public aren't seeing what's happening in the hospitals or talking to the doctors or the nurses. So how did you manage that when you were writing about this? How did you kind of deal with those feelings and that feeling of burnout that you might be getting, that I know a lot of journalists have expressed to me over the last year and a half that they've started to feel, obviously in a different way because you're not in the hospital taking care of the patients, but taking on those stories and hearing people talking about what's been happening over the last year and a half, that has to have had an impact. And I'm curious as to how you were able to put out this phenomenal book while still maintaining your own mental health and your ability to keep pressing forward.
Yeah, that's a great question. I mean, one of the things that really kept me feeling motivated and honestly even hopeful throughout the process of working on this book was the conversations with the doctors who are in it, because they are an exceptional group of people, and they're not only exceptional doctors, they're also just people who are funny and joyful and manage to find so many outlets for optimism and even fun and levity in the context of the pandemic. They were able to find these moments of connection, whether with their coworkers, their patients, their families, their partners, and getting to kind of hear how there was this intermingling for them of the grief and the joy and just all of these high highs and low lows. I feel like I was, living vicariously through some of that, and just getting to form relationships with them was definitely just the highlight of the year. Really, I think they're people who have taught me so much and showed me what it looks like for someone to be placed in an exceptionally difficult situation and above and beyond step up to it, grow from it, be challenged by it, and just kind of contribute to their community. So all of that, like, I feel like I just soaked in all of their inspiration, and that really kept me going.
Do you worry that there's a flip side to that altruism, that, in some ways, I think there's a morality that's woven in to the stories in your book, and certainly a lot of what the young doctors were asked for, they were able to draw on some of those internal resources to act in ways that were difficult. And there started to be a dialogue around whether that altruistic moralism, that internalized conscience that we've all created for ourselves, whether that is exploited at times and actually leveraged against us. I wonder if you saw that.
That's a really fantastic question. And it's something I've been thinking about, is like with medicine, it's a really, it's a field that demands so much from people. It demands, hours and hours, sometimes 12-hour shifts, sometimes all night, sometimes 24-hour shifts. It's exhausting. And I think it's also in a lot of ways mentally and emotionally exhausting in ways that people don't always talk about, because it's thought of as this career path that at least is stable and, a good, steady income, and it's prestigious and it's respected. And so I think we don't always recognize just the gravity of the emotional weight and the psychological weight that's placed on people when they're going day to day through exchanges that demand so much of them. And they don't always get a sort of release for that. And they think they have to build up this sort of like emotional armor to it. And I think what really stood out to me was some of the doctors who I spoke to who described some of the things that they saw the past year as moral injury, where they felt they were witnessing things that were just not right, even though they were following protocol and the hospitals were following protocol, but there was no way for them to accept what they were seeing whether it was losing a patient whose family couldn't be in the room, or the opposite. I spoke with a doctor who was caring for a patient, and the patient's daughter was sick in the bed next to her, and the patient died with the daughter lying right there as well, hearing it, and hearing the code. And so I think the doctor described watching that as a kind of like sense of moral injury, of thinking he was watching something that he felt sort of powerless over, even though he was going through the motions of doing his job and trying to care for everyone in that situation. And so I think we are going to have to reckon, especially coming out of this crisis, with what it looks like to provide support for doctors who have just had an impossible emotional and psychological weight placed on them over this last year, and have had to see things that no one should have to see, and feel even a level of responsibility and culpability for that.
That's where we need to tag in the fabulous Jessie Gold.
Exactly.
To help all of us. And, so many of the physicians that you wrote about, their first patients died. And that struck me because it's so different, obviously, from what you think you're going into medicine to do. And I wonder what that brought up for you in terms of how well medical education is preparing these physicians for what they actually face versus what we may in theory believe our jobs to be.
That was something that definitely stuck out to me in the moment, and has stuck out to me ever since. The doctors who, within hours of, starting on their first day as MDs, as doctors, had to lose their first patients. And especially one of the doctors I followed, the first time he wrote down his name as an MD was a death certificate. And another of them, also was one of her first patients who she admitted. He passed away before she could even get his family on the phone to talk with him. And those are moments that I've continued to think about ever since as well. And I think that there's no way to really emotionally prepare someone for those moments, because it's the kind of thing, how do you fully help someone anticipate what that's going to feel like, but especially in the context of a crisis where you then just have to leap immediately back into action. And so I think the decision to graduate the students early and have them serve, I think, certainly was a powerful one, because they were sitting there wanting to help out. Without fail, all of the doctors in my book were saying in the days leading up and the weeks leading up to starting in the hospitals that they desperately wanted to help, because they were seeing their city and their communities be ravaged, and they knew they had the skills and they just wanted to be there and help. But I do think there was a degree to which, like, how could they have been prepared for what that would actually feel like to be in the wards in those early weeks in New York, especially when it did sort of feel like the war, like a war zone. As much as that's a complicated metaphor, I think it did feel that way to a lot of them. So I think it certainly raises questions about what does it look like to prepare someone for those kinds of moments.
I'm so glad you brought up the topic of war metaphor, because that is, I think, one of the ways that we control the narrative around what we're asking people to do. And the fact that, they were termed coalition forces as young physicians, and, there's that whole hero narrative. As someone who clearly loves words and understands their power, do you have thoughts about the intention behind that and what it makes available and what it suggests to them?
Yeah, I was fascinated to hear the really wide range of feelings about that metaphor. And I spoke with some high-level doctors at Bellevue who were running the response, who found it really galvanizing. And they, what they said was, this is accurate. Like, this is our army. Our staff is our army. And we're trying to rally them around to feel like we are in this together, and there's a sort of battle to be won. And I think the flip side of that is, like, was there a battle to be won? There were certainly always going to be losses along the way, and losses that no matter what the doctors did, they wouldn't have been able to prevent. And there actually are really interesting studies that show that the wartime language, particularly when it's used around cancer, can be really disempowering for patients because it makes them feel like setbacks and, severe illness and even death is a loss. It's something that could have been won that they failed to win. And so that language can be actually harmful to patients' mental health. There's a great linguist named Elena Semino who's done really interesting work looking at that sociologically. And I think that came out, that aspect of it came out a little bit in my conversations with some of the residents, because they spoke to the fact that there actually is a real tension between the language of war and the language of the Hippocratic Oath, and the idea that you're doing no harm, that first and foremost, what you might be able to do in a given situation is show up with your humanity and your comfort, and just be present for patients. And that's not really accounted for in the wartime framework, where it's either about, victory and going on the offensive or loss. So there's a real complexity to it. And I think some of the doctors I spoke with found it really inspiring and helpful, and others really wrestled with it. And I think we're probably going to have to continue wrestling with what it did to patients and over the long term, because it can ascribe, a sense of choice and of sort of, absolutes that isn't always there with serious illness.
And I do think that it is tied to the issue of moral injury, because the notion of war does suggest that normal rules are suspended and that there will be casualties, and you will be asked in some ways to betray yourself in certain situations. And that is what leads to moral distress. So it almost feels as if it can be used as propaganda. And I worry about us buying into it. I understand the galvanizing force of unity, but there's so much else that comes with it, so much baggage that can be attributed to it as well. So I appreciate that discussion. Would you read us a part of the book? Your words are so beautiful.
Thank you so much. Yes, I have a passage that I picked out to share that I thought actually would also be particularly a good fit for this, because the doctor who I followed in this particular passage, Iris, started out this conversation that we had on one of the days right around when this had happened by talking about In Shock, your memoir, and talking about how that had impacted her and shaped her idea of how to communicate with her patients in a loving and respectful way. So that was something that was kind of threaded through this particular narrative that I wanted to share. So I'll start now, and this is from the middle of the book, so sorry to drop everyone into that. So this is from May 2020. No one was under any illusions about the survival prospects of a patient hooked up to a ventilator. Some Montefiore residents said that in the first weeks of the outbreak, half of their ventilated patients died. That was the knowledge they had to hold, an impossible weight, when introducing themselves to their patients struggling to breathe. Iris was assigned a patient named Mr. Johnson with a severe case of COVID-19. When she went to greet him, she saw a large man, African American, who had been given a tracheostomy, a hole cut through the neck into his windpipe to allow for easier connection to a ventilator. It looked like a plastic collar encircling the neck with gauze underneath. It could be somewhat safer than normal intubation because it prevented scarring and ensured he couldn't instinctively knock the uncomfortable tube out of his throat, accidentally cutting off his own oxygen supply. But it was often used for people who needed to be on a ventilator for a longer period of time and could suggest a more complicated process for recovery. Mr. Johnson was also on heavy sedatives and fentanyl. "Hello," Iris called out, making sure to raise her voice above the noise of the floor. "I'm Iris. I'll be taking care of you." She was greeted by silence and hollow eyes. The machines around her patient beeped and whirred like a conversation in which he couldn't partake. Iris was somewhat surprised to read that he was marked full code. His last doctor had spoken with his sister, who is adamant that if his lungs or heart failed, she wanted any intervention that could possibly save his life. They had their marching orders: do everything. This didn't entirely make sense to them given his medical state, and they had been clear about his slim chance of a meaningful recovery. But it wasn't their place to overrule his family. Iris came by again in the afternoon when there was a lull in her shift. "How are you?" she asked him. "I'll be here checking up on you." No response. He couldn't make eye contact when she spoke, which made Iris feel all the more ridiculous for her bubbly greetings. But these seemed necessary too. "I'm always around," she told him, "if there's anything you need." She noted his left hand dangling downward in an awkward position, so she leaned forward and lifted it gently. "I'm going to move your arm back," she called out, "just to make sure you're comfortable." Iris had cared for other ventilated patients who were more responsive. One woman, when asked to lift her hand up, mouthed to Iris, "I'm trying." Then Iris asked, "Are you in pain?" The woman shook her head no. "Is anything hurting or making you uncomfortable?" Again, no. At the beginning of medical school, when Iris was dizzy with all the abbreviations she was meant to memorize, she had resolved that she would master the clinical vocabulary, but not its tone. She was unsettled specifically by the patronizing way in which some physicians address their patients. She remembered her own diagnosis with depression and knew she wanted to be the type of doctor who made her patients feel like partners in the medical process. Subjects, not objects. This was tougher with some of her COVID patients like Mr. Johnson. They couldn't speak and wouldn't even show a change in facial expression when poked and prodded by their nurses and doctors. It was difficult to know whether they comprehended anything the medical team said. But in her third year, Iris had started reading the medical literature on patients capable of hearing, even in altered states of consciousness. She became consumed by the idea of patients slightly cognizant of their surroundings who weren't fully told what their doctors were doing to them. The loss of autonomy seemed so painful. Iris decided that regardless of whether her patients could engage her, she would always provide them with information on their conditions and care. Now, during COVID, that seemed even more necessary. Iris struggled to decide what she should tell Mr. Johnson's family by phone. She didn't want to give any of them a measure of false hope, and his prognosis was poor. "Tell him I'm praying for him," his sister said on the phone. Iris promised she would. In what was both good and bad news for Mr. Johnson, Iris's team soon decided it was time to wean him off fentanyl, as well as sedatives. Opioids suppress the respiratory drive, the body's compulsory fight for oxygen, and they wanted to see if he could start to breathe on his own. This was important because his family wanted everything done that might help him recover, which meant getting him off supplementary oxygen at some point. Iris and her team began decreasing his dosage with the goal of tapering it off completely. His first day off the medication was a Thursday morning. He was Iris's first patient on pre-rounds, and she had to wake him to his first non-sedated, non-medicated morning. She touched his shoulder gently. "Mr. Johnson," she called out. No response, still no eye contact. "Your family has been praying for you," she told him. "They said to tell you how much they love you." For the first time since he came into her care, Iris saw him somewhat register her presence. Then, to her disbelief, the man's eyes began to well up. A single tear spilled over onto his cheek. She was overcome with the desire to look away, to fix her eyes on anything but his face. He still couldn't hold her gaze, but his brow was furrowing, like he was beginning to come back into his own body. Iris grabbed his hand. "Oh, I know," she said. "I know it's hard." So
Wow.
that was a passage that really stuck with me because I saw how she was kind of in real time trying to put into practice the lessons she had learned about what it meant to kind of honor a patient's emotional needs and think how to kind of go above and beyond the clinical care to offer her humanity and her presence.
And still coming against the limits of her own ability to be present for it without having her own suffering to attend to, which I don't think we equip doctors well to know how to meet that space.
Yeah, exactly. I think there's a real, there's a real, moment where you realize that your presence is everything to a person, and that can be a lot of, responsibility.
And it's beautiful to me that the dehumanizing aspects of COVID made her want to be more human and bring more humanity. I remember one of the days in the early surge, I had this habit of going around to see what the worst part of everyone's day was, just so I could depress myself. And I came up to one of the ICU nurses who said, "I can't tell my patients apart. They are all the same. They are the same ethnicity. They have the same comorbidities. They're on the same vent settings. They're on the same drips. they might as well just be bodies. And she was so damaged by that, you know, not knowing how to see them as people because their families weren't present. And she had no history outside of what we knew because they came intubated to us. And finding ways to reinsert humanity in this pandemic, I think, has been in some ways the hardest work and also the most rewarding.
Yeah, I think that's so powerfully put. I definitely I heard that as well from a lot of people, and especially the kind of challenge of communicating when you were behind all these layers of PPE and your patients were as well, and that made it difficult to even speak and to, you know, properly be heard, especially when the patients didn't speak English and you had to also get an interpreter on the line. And, you know, on top of that, not being able to really use your facial expression in the way that you normally would. And so there were all these kind of barriers to communication and to emotional connection. And I think that really weighed on people, all the more so when patients couldn't have their family members in the room. And I really heard that, especially in the context of doctors thinking about how to facilitate goals of care conversations. Yes. And not knowing, especially when, you know, they couldn't have a family member sitting at the patient's side. And then, you know, oftentimes they were straining to be heard, and especially when they had to get an interpreter on the line. And at the same time, you were having the most emotional, challenging conversation you can have with a person. So I think those are the moments that that also really stick out to me. And at the same time, those conversations were more necessary than ever.
And you're writing such a gift for that reason, because I think we as medical providers have been struggling with how to make the invisible visible. It's one thing if a family member is sitting by the bedside of a deteriorating patient to be able to show the body shutting down in a very visceral way. You know that if you're in the room, it becomes something that's known. But when you're excluded from that, it's very intangible. And the kind of conversations we had to have around that were very difficult. And so you're serving as a kind of intermediary here to allow people in. And I think there's so much value in that.
Oh, thank you for saying that. And yeah, I was really struck by the number of doctors who told me in other words, sometimes that working during the COVID crisis was sort of the palliative care fellowship or, you know, training that they hadn't previously gotten, that some of them just started to have goals of care conversations constantly, and they never got any easier, but you know, it still was this kind of training and exposure that people couldn't ordinarily have gotten, at least in that quantity. And I think those conversations are so challenging, and they're so hard to kind of understand from the outside, and particularly from the perspective of family or, you know, patients who aren't, or people who aren't in the hospital, or kind of what does that mean? What does that look like exactly? Mm-hmm. And I really wanted to find ways of sort of translating what it meant to be sitting there for those impossibly hard conversations.
And that was another space where I think we saw unity early on that we're not seeing now. I remember one of my colleagues having an end-of-life conversation with a family by video and explaining that it was unlikely that CPR would result in a return of life. And the family member very clearly saying, I don't want you or your team risking more exposure by doing that, because you guys need to stay well for other patients. We need you. And it was those moments that I think that kept us going, that sense that the care was valued and understood, and the risk that we were assuming was seen. And I worry what the consequences are that we've lost a bit of that and how we can get it back. And certainly books like yours are one of the ways. I wonder, as a journalist, if you have other ideas about communication that could bring us closer to that sense of interconnectedness again.
Yeah, well, one of the things that I have found really powerful over the course of the last year is the number of physicians who have found platforms for sharing their narratives and their experiences, whether that's on social media or in speaking with journalists or writing essays and other kind of narrative work. I think that those stories are so powerful, and that doctors, I've spoken with doctors who frame that kind of writing as almost something they're doing for themselves. And I don't think it's always recognized how much that impacts others. And, you're someone who does so much powerful writing and sharing on social media. Jesse Gold, who we've shouted out, who, suggested this event, is another person who has been such a prolific storyteller this past year. And I think creating as much space as possible for doctors to share those stories, and not always in really, edited or stylized ways, because we know there isn't always time for that, but just getting out the experiences. And there, especially in the last few weeks, there have been these moments when I've seen on social media doctors sharing stories of times when they've convinced someone who is hesitant to get the vaccine. And those stories always sort of make my day, and also make me realize that this is doable, that those conversations really move the needle. And I think it shows other people the same thing, that engaging with people who are hesitant or fearful for whatever reason can be really fruitful. So I think we can't discount how important doctor storytelling is. And I think social media has been huge for that this past year, especially. I think people are yearning for communication and storytelling and connection, whether virtual or not, more than ever right now, because so many of us are still in a lot of ways very isolated. So I think continuing to amplify those stories is something that's so important to me, and that I'm hoping to continue to see other journalists doing as well. And I'm also curious to hear from you, as someone who does so much narrative medical work, and also teaching about narrative medicine. Has this shifted your understanding of the kind of role of narrative within medical education as well?
It's interesting because it's evolved a bit. I think I've never believed more in the power of story. One of the things I felt kind of guilty about with my book was that I was saying things that patients had always said and weren't validated because it was a patient voice. And so the narrator, being a physician, somehow gave it value. And I thought that was wrong. And I felt ashamed that I was that person that was in some ways usurping the patient narrative. Although it was with the best intentions. And now, again, I feel like we are trying our hardest to put these stories out that might change minds, that might offer a different way of seeing or knowing that isn't accessible otherwise. And I will never stop believing in the power of that as a gateway. But I worry that we've got some barriers right now that are not allowing those stories in, that we've become so polarized that unless the narrative is affirming, we're not even reading it. And I don't know how to break down those silos. I'm interested as a journalist if you have thoughts about that.
Yeah, that is a really, really critical point, because I think that is something that struck me with your memoir as well, is that it shares some truths that I would imagine are uncomfortable for doctors to read and process, and in some cases uncomfortable for patients, because it's validating realities that are challenging and that we wish weren't that way. Whether it's that idea about doctors, being trained more to see pathology and not always the human in front of them. There's all these ideas that I think are really hard for us to sit with. And as a journalist, that is, really the core of my work, is that you have to report what you hear and what you see, and not what people want to hear. And I think that's such a core tenet in journalism, and thinking how to ensure that that spills over into all the kinds of storytelling that's happening right now. I think that's really critical, because I think there can also be, in some ways, an orthodoxy in medicine and a reticence to criticize the norms, the establishment, the kind of tried and true ways of doing things. And, you don't move forward without that kind of criticism. So I really do hope to see us all sort of think about how to sit with the discomfort in sharing stories that don't line up with the way we'd like things to be.
And I think your example about vaccine conversations is the perfect sort of gateway into a lot of this, because there's an oversimplification in some ways of why people are not getting vaccinated. It's become somewhat reductive, and it's only at the individual story level that I think we really can understand where the hesitancy lies. But we have to be willing to engage in those conversations, and I think everyone's a bit tired, so having your encouragement goes a long way. Is there anything that you wish had made the book that didn't, or in retrospect that you wish you had included?
I think one of the challenging things was knowing when to cut off the reporting and the narrative, because obviously this crisis is unfolding day by day, and more than a year since I started reporting the book, it's still continuing to evolve and unfold. And so knowing kind of how to capture a snapshot in time without, while making it clear that that wasn't the full story, because it never could be, that was one of the things I struggled with. And I very much didn't want it to be a story that kind of implied, this was New York's COVID experience, because it was a tiny, tiny sliver of it in a crisis that we're still trying to figure out how to navigate. And so that was why it was important to me to keep it pretty contained to the few weeks that the doctors spent really in their sort of frontline pre-residency assignments, because otherwise I knew that I could have just kept, recording, documenting forever, because they're still going at it, and they're now in their past their intern year. So that was probably one of the most challenging things in terms of framing the narrative. But there also were a lot of other doctors I connected with whose stories I wish I could have included, who I wasn't able to, because I had to, at the end of the day, narrow in on a couple of the central doctors in this book. But there is still doctors I'm in touch with, and one of them who I wrote a piece for about recently in The Guardian about some of what he saw in terms of his own mother falling very sick with COVID in Texas. That was a story that really touched me, so I was glad to be able to document it even outside the context of the book. And
I'm sorry, go ahead.
I just wanted to say also that if anyone had questions that they wanted to write in the chat for either of us, we can definitely keep an eye on that as well, just because I am cognizant that we're, running a little short on time now.
Well, I can tell you, I've been monitoring the chat, and the majority of the comments in here have been talking about how everything you are both saying is completely spot on. And Dr. Tatiana Prowell actually put something really interesting, which I do with a lot of my patients, is, as she said, that sometimes it's nice to have a picture of a patient before they were admitted to the hospital to kind of maintain that humanity. And I tell my trainees that all the time, to ask for a picture so that they know that the person they're taking care of is a person, and so you don't lose that humanity. And then someone else brought up the point about storytelling and bullying and harassment, and how women in medicine especially really try to use the narrative and oftentimes are penalized for it, as we've seen happen with physicians throughout the pandemic, where there have been physicians who went to the news or who told their story to a journalist and ended up losing their jobs because they were sharing their truth and sharing the truth of what was happening during the pandemic. So I think both of you use your voices so powerfully to share stories that need to be told, and oftentimes need to be told by the right avenue, by the right voice, that is not seen as a polarizing voice, is seen as somebody who is presenting facts and in an affirmative way, as Rana mentioned earlier. So that's some of the stuff that's been in the chat. But I think that, we've got about 5 minutes left. So whatever we've fit so much into this 1 hour, I could listen to you guys talk for hours and hours. But if Rana, if you want to have maybe one more question or one more thing you want Emma to cover before the end of this session today.
I have one last question. It's perfect timing. I was struck by how gracious you were. I watched an interview you did in recognizing that you know, these trainees were making time to have these conversations during what was a very consuming period of their lives. But I wonder also if you were creating a safe space for them that medicine hasn't necessarily created. And if you sensed that in your relationship, that this was in some way a healing or nurturing environment for them.
Yeah, that was some of the best moments for me were when some of them reached out and said that they'd experienced it as like therapeutic to be able to process and reflect and unload in some ways some of the things they were seeing, whether it was because they didn't want to put that burden on their families or their partners, or just because, you know, they didn't necessarily have those other spaces to just share day to day what they were seeing. And that just was so gratifying for me, because that was my biggest worry, was that this would be just too much of a burden on top of their impossibly busy schedules. So it was really gratifying to hear that some of them experienced it that way. And I do think that in the best of cases, journalism can hold that space for people. You know, it can provide people with a space to narrativize what they're seeing and experiencing, instead of just moving through the motions of the day-to-day. You can kind of step back and draw out the moments that really stayed with you and touched you. So I've always thought there's some sort of overlap between the work of almost you know, therapists and journalists, and that it's so much about the listening and the holding space. And so I was gratified to be able to do that in some way, even though I still feel just like overwhelming gratitude to them still for making the time, because I know that in some cases it was a lot on top of what else, you know, all the other obligations they had.
And I think that's something that certainly will be a takeaway that I get from this, from your writing, is that we can model that as peers, as colleagues, as supervising attendings, we can model what you do, and we can listen non-judgmentally and with curiosity, and aid them in sense making and cognitive restructuring of their experience. And that's a different way that we can create a safe space for our trainees. So thank you for that.
Thank you so much. I mean, again, it's just, I'm so excited to be able to do this conversation with you, because you really impacted how I think about the ways medicine is changing and what the best of patient-doctor relationships can look like, and the role of storytelling in medicine. I think you've really been a champion of the importance of making space for people's voices, and for everyone's voices, not just, you know, the normative voices of medicine. And so I'm so excited to be able to talk about all of this with you, and grateful to everyone who wrote in the chat as well to share their own experiences.
So with that, I'm going to wrap up this amazing conversation. Like I said, I really could listen to both of you talking for hours. We put the book link in the chat again, so please make sure you buy a copy. This session is recorded, so I know it was in the middle of the day, so it was challenging for a lot of people to attend, but we have a lot of interest and a lot of engagement on social media. Dr. E. Bloomgarden has been live tweeting this conversation, so we're happy to continue the conversation on social media. And this recording will be available to anyone who's interested in listening. We'll make sure to distribute it widely. I want to give a huge thanks from both the Women in Medicine organization and also from IMPACT, the Illinois Medical Professionals Action Collaborative team, who are the co-sponsors of this event. The two of you have had such a huge impact on healthcare, on medicine, and especially in this last year and a half. I don't think many of us could have imagined that we would be talking about this still a year and a half later. But Emma, your book is just outstanding, and everybody should get a copy of it. Rana, your book is also outstanding. So if you haven't read Dr. Rana Awdish's book yet, please buy her book as well. They're both fantastic books. And again, a huge thank you for joining us today. And anyone else who is joining or who's watching this recording later, don't forget to sign up for the Women in Medicine Summit. It's September 24th and 25th. It is virtual because we are still in the middle of a pandemic, but hopefully we'll see you all there virtually. And Emma, I can't wait to hear what people have to say on social media about your book, and hear all the amazing comments from the people who listened today, because really this was an amazing conversation, and I really want to thank you both from the bottom of my heart for joining us today.
Thank you so much. Thank you for creating space for this.
Yes.
And everybody else, we'll see you September 24th and 25th, and we'll keep the conversation going on social media. Have a great rest of your day.